Welcome to the UNC Core Center for Clinical Research Speaker Series. We appreciate you taking the time to join us for today's presentation. Our presenter today is Dr. Candace Feldman, an assistant professor of medicine in the Division of Rheumatology, Inflammation, and Immunity at Brigham and Women's Hospital and Harvard Medical School. Her presentation today is titled Disparities in Rheumatic Disease Care, From Description to Action. Dr. Feldman, feel free to start whenever you'd like.
I'm Candace Feldman. I'm excited to be here or at least virtually here with all of you and giving this talk today. So, please do feel free to interrupt me and ask questions, and I'm going to do my best to talk quickly and so that there's plenty of time for, sorry, hold on one second. What's happening? Just want to make sure that my email is closed, which it was. Sorry. Okay. Okay. Good. Sorry about this. I don't understand. This is I specifically wanted to make sure that I could present from my office with the idea that it was gonna be easier. Are you seeing my screen now? I apologize.
Yeah, it's just the one slide, so that looks correct.
Okay. And are you seeing this like email thing popping up as well, interrupting it, or no?
No, I just see the slide.
Okay, good. All right, so I'm going to start going. All right, so I have no relevant disclosures, and I'm excited today to tell you that about some of the work that we've been doing related to disparities in rheumatic diseases. So I have no relevant disclosures, but I do serve on the board of the American College of Rheumatology and receive various research support. So I have a couple of objectives today. First, I'm going to go through a couple of definitions just to kind of ground us all, even though I know that there are many researchers in this group and many disparities researchers, as well as I've read work of a number of people in this group as well. Then I'm going to talk a little bit about disparities in lupus care among Medicaid beneficiaries, which is some work that I've been doing over the years with our research team here at Brigham and Women's Hospital. And then I'm going to move past sort of talking about some of the disparities and talk more about some of the interventions that we've done around these issues. So first, just so that we're all on the same page, what is a health disparity? So a health disparity is a difference in which disadvantaged social groups who have persistently experienced social disadvantage or discrimination systematically experience worse health or greater health risk than more advantaged groups. So disparities arise from a number of factors. They arise from differences in the quality of care and preventive care, from differences in life conditions, which are like opportunities, exposures, stressors, support, and from societal structures that are perpetuated over time, such as racism and income inequality. So now I just want to talk a little bit about social determinants of health, which is another kind of key term that I'm going to use throughout this presentation. And this is a term that has now moved into the forefront of conversation and is in the newspaper and everything. So I think it is a sort of much more common concept than I think it was maybe 5 or 10 years ago. So social determinants of health are all of those factors that go into what makes a person healthy or unhealthy. And I think for me, what's important to think about here, and as a practicing physician, that's one of the things that for me is also very important to remember, is that medical care is really only one piece of the puzzle. And so much of what we do and so much of what we think of revolves around sort of the care we provide, the health system. But, I think for me, one of the most important things to remember, and really the subject of a lot of the research I do, is recognizing that is only one piece of the puzzle, that there are so many other factors beyond the healthcare system that also contribute to the way in which people interact with the healthcare system, which is what makes a person healthy or unhealthy. So, first starting at this kind of broadest area, the economic and social opportunities and resources. So thinking about fundamental like income inequality, and then examples like that include structural racism and other structural factors that relate to access to employment, to education, to healthcare. Thinking about living and working conditions in homes and communities, so neighborhood poverty, racial residential segregation, discrimination, safety, housing stability, environmental exposures, medication and appointment adherence, healthy and unhealthy behaviors, thinking about these personal behaviors, but also remembering that personal behaviors also exist within a whole system, right? So much of what leads to these behaviors are related to the factors that span the whole system. And then finally, medical care. So what is the quality of care provided? Do patients have access to subspecialists, to preventive care, to ambulatory care versus acute care? So emergency department or hospitalization, is that where patients are able to receive the majority of their care, or are they able to have sustained access in the ambulatory care setting? What is the quality of care that patients are provided? Do patients experience discrimination, whether it's by race or by gender, or by weight? And then do all individuals have equal opportunity to participate in research and have an access to sort of the newest treatments and to be a part of the process of development of medical knowledge? So now to ground you, so I'm a rheumatologist, and so I think a lot about chronic rheumatic diseases. And just to tell you a little bit, I know a number of you are rheumatologists or rheumatology researchers, but just to provide a little bit of background. So 25% of the US population, so about 54 million people, live with a chronic rheumatic condition. So chronic rheumatic conditions are, it's sort of a large kind of set of diseases that include autoimmune diseases like lupus, autoinflammatory diseases that include genetic factors such as familial Mediterranean fever, and also conditions like gout, and also arthritis that range from autoimmune or inflammatory arthritis to osteoarthritis as well. So what brings all of these conditions together is that a number of them require complex, costly medication regimens. Nearly all individuals who have chronic rheumatic conditions also suffer from a high burden of comorbid conditions. There's a significant association with cardiovascular disease, with cerebrovascular disease, with metabolic syndrome. There are also significant physical disabilities. Arthritis is the #1 cause of disability in the United States. And also there's a strong relationship with mental illness, and specifically depression, that really runs with many of our conditions. The other thing specifically among patients with autoimmune and autoinflammatory diseases is that there's a high risk of care fragmentation, because individuals with our diseases tend to require care from a number of different providers, including subspecialists. And there's a very high risk for disjointed and lower quality care, and also for frequent emergency department visits and hospitalizations, which I'll show you in a little bit as well. And then thinking back to that schema that I showed you previously, social determinants of health have been shown to contribute in a number of ways to rheumatic conditions, as they do to all chronic conditions. They contribute to delayed diagnoses, to increased acute care use, to medication non-adherence, and to increased disease-related damage and poorer outcomes as well. So systemic lupus erythematosus has been the subject of a lot of the research that I've done in our group at the Brigham. And so I'm going to tell you a little bit about the disease and a little bit about what kind of has been shown broadly as it relates to disparities in this disease. So lupus is a chronic autoimmune condition. It has a huge range of manifestations, from very mild disease, which can include some aching in the joints and some skin manifestations. Those skin manifestations can also become extremely severe. Joint manifestations can also become severe. And then it can also span to life-threatening conditions, including end-stage renal disease and cardiac complications. We know that there's a significantly higher burden of disease, as well as a higher burden of adverse outcomes among African American individuals, among Hispanic individuals, and among American Indian and Alaskan Natives. There have been several studies that show that lower neighborhood socioeconomic status is associated with increased depression in lupus, and also that higher neighborhood poverty is associated with greater lupus-specific damage. In addition, individual poverty has been associated with greater damage. And interestingly, a study by Dr. Yellen and the group at UCSF has shown that actually moving out of poverty is associated with a reduction in damage, which is, I think, both very interesting and very important. Studies have shown a higher risk of adverse pregnancy outcomes among African-American mothers with lupus, and also studies repeatedly show an increased burden of comorbidities among African-American individuals living with lupus, including hypertension, renal disease, and cardiovascular disease. There's always when things are talks about disparities, there's always sort of this question of are there genetic factors that contribute? And as you'll see from my talk, I do have some significant beliefs on thinking about race as a social construct and not as a representation of genetic ancestry, as has been shown repeatedly. I should mention, however, that there is the ApoL1, G1, and G2 alleles have been associated with increased risk of end-stage renal disease among patients with lupus nephritis. And these specific genes are present in high frequency in some African-American individuals and are nearly absent in European Americans. What I will say here about this is to think about this with some caution, because we really cannot conflate race, which is, as we know, a social construct, with genetic ancestry. And so I think that's an important thing to think about too as we explore disparities. Now I'm going to talk a little bit more about disparities in lupus care among Medicaid beneficiaries. So as you know, Medicaid is the largest public health insurance in the United States. It's run jointly by the federal and state governments. This is a map actually from 2016, and it shows that about 19% of the US population is covered by Medicaid or by CHIP, which is the form of Medicaid that covers children. So in sum, it covers 1 in 7 adults in the United States between the ages of 19 and 65. Oh, sorry, was there a question? Oh, no, okay. And here you can see on this map that because it is jointly run between the federal government and the states, there is variation, both in terms of the percentage of populations in each state who are of individuals in each state who are enrolled, which is in part related to this different definitions that states use to include participants. So before the Affordable Care Act, which is where most of our data come from for the presentation I'm going to show you, these states use different levels of poverty in order to define their enrollment criteria. And in many states, it wasn't just criteria by poverty status alone, but it was poverty status and something else. So poverty status and disability, or poverty status and being pregnant, et cetera. So because of the variation in these definitions, there's variation in enrollment across the country. So one of the first studies that we embarked on was defining the burden of lupus in Medicaid. So because we know this is a vulnerable patient population, which primarily supports individuals who are of low income, there is a significant burden of chronic diseases in general. So we hypothesized that we similarly would find a significant burden of lupus, probably higher than what had been previously described higher than what had been previously described in other nationwide studies. So what we found was in fact a higher burden of lupus in this population, and significantly increased risk among individuals who identified as African American compared to white, with more than 2 times or approximately 2 times the risk. We also found a significantly higher prevalence of lupus nephritis, so lupus in the kidney, which is one of the most significant adverse manifestations of this disease in all non-white race ethnicities. And then one of the other things that we found was that we used a sort of composite zip code level index based on work done by Michael Ward at the NIH to create quartiles of socioeconomic status by neighborhood, and found that areas that had the lowest socioeconomic status indices, had the highest prevalence of lupus, even after adjusting for race, ethnicity, age, and sex. So the challenge here is that, there is certainly a possibility for reverse causation. It's hard to know whether living in poverty increases your risk of developing lupus, or whether once a person develops lupus, they have a higher risk of moving to areas of poverty because of loss of work, disability, et cetera. So hard to know exactly which direction this goes, but certainly do see an association, and this has been shown in other data sets as well. So the next question we asked was, are there disparities that we see in outcomes among patients in Medicaid who have lupus? So what we found was a very high burden of serious infections. We define this as infections that result in hospitalization among individuals with lupus enrolled in Medicaid. We know that lupus in itself predisposes individuals to serious infection, and then the immunosuppressive medications that we use to treat the disease also contribute to the risk. However, the rates that we found in this population were significantly higher than any other population that had been demonstrated, suggesting probably many risks for development. One other thing to note is in a study that we are finishing now, we found very, very low rates of vaccination in this population. And it does raise the question of how many of these serious infections could actually have been avoided if patients had appropriate access to preventive care. So what you can see here in the table is that we did find a significantly increased risk of development of serious infection or hospitalization for serious infection among individuals who are Black, and also among individuals who were American Indian or Alaskan Native. And not surprisingly, we found increased risk associated with glucocorticoid or steroid use, as well as immunosuppressants. And another thing to note is that among those individuals who were hospitalized for serious infection, the 30-day mortality was also extremely high in this population. So our group also explored other outcomes, including mortality among individuals with lupus, and found rates that were significantly higher than lupus-related mortality that had been shown in academic cohorts, suggesting that individuals who are low income, who have multiple chronic diseases, likely have higher rates of mortality from this disease compared to individuals who are in general also healthier and maybe accessing care at higher or in a much easier way. So here we found higher rates among American Indian, Alaskan Natives, and also among African Americans compared to white individuals. And among patients with lupus nephritis, which sometimes can progress to end-stage renal disease, we also found higher rates among African American individuals and also more cardiovascular events. Interestingly, in Medicaid, we did find lower mortality among individuals who identified as Hispanic and also among individuals who identified as Asian. It is interesting because this is not necessarily true for other populations, and we do other data sets compared to Medicaid. And I do wonder whether it has something to do with both how race ethnicity is defined in Medicaid and also who is eligible for Medicaid. So for example, undocumented individuals are not eligible to receive Medicaid. There is also in the literature a described Hispanic paradox that suggests that at times individuals may return to their home countries at the point where they're nearing death. And so it's possible that we're undercounting this or misclassifying individuals as well. So I'm not entirely sure how much weight to place on this. I think it's sort of an intriguing finding that warrants further investigation, specifically in how we define racial ethnic groups in Medicaid. So the other thing to note is that there are significant disparities in lupus outcomes when you compare the Medicaid population to an international academic cohort population. So here you can see risks of end-stage renal disease and death among Medicaid beneficiaries compared to an international academic lupus cohort. And you can see here that the 5-year cumulative incidence rate of end-stage renal disease among Medicaid beneficiaries is about 13% compared to a 10-year cumulative incidence in this academic cohort. And similarly, a significantly higher increased risk of death or cumulative incidence of death. So I think that to me, this does sort of raise two questions. So one, are patients who are enrolled in Medicaid just fundamentally sicker than individuals who are receiving care in academic cohorts? this sort of second question there is there a difference in the quality of care that are being provided to Medicaid beneficiaries compared to individuals who are part of academic cohorts? I won't go into this in too much depth, but there is a thought in lupus that while it is a predominantly female disease where about 9 times higher rates are seen among women compared to men, that men may have more severe lupus, or there may be delays to diagnosis that result in more severe presentation when at the time of diagnosis. So we did look at this question in Medicaid and did not actually find significant differences in outcomes comparing women to men. And we do wonder whether it's in part because there are other sort of vulnerabilities in this population that may override whatever biologic differences that may exist. Either that, or it's possible that really some of the biologic differences may not be as significant as has been previously described. So thinking a little bit about quality of care provided to patients in Medicaid, one of the things that we notice when we see differences in outcomes comparing Medicaid to other cohorts is this question of, well, how much of this is because of the care that's being provided. So one thing to note is that individuals with lupus tend to be young, they tend to be reproductive age, and while many individuals with lupus have very successful, healthy pregnancies, it is important to time it at points where the disease is well controlled. In addition, there are certain medications that are used to treat lupus that are teratogenic, and so thinking about contraception is important. So one of the things that we looked at are there racial differences in contraception access and sort of encounters for contraception by race in this population. So overall, we found that only 15% of beneficiaries with lupus had any encounter for contraception management, which is very low. One does also wonder whether maybe they are happening, but it's just not being billed for because this is administrative claims data. And only about 16% received any form of contraception, and 4% received what's defined as highly effective contraception. So this includes like IUDs, for example. So one thing that I'll draw your attention to that I thought was very interesting is that individuals who are Black and Hispanic actually had more encounters for contraception than individuals who were white and were Asian. But interestingly, this did not necessarily translate into increased prescriptions for contraception, and specifically highly effective contraception. So here you can see that from multivariable logistic regression analyses, where there was a significantly increased odds of an encounter for contraception, but specifically among individuals who are Black and Asian, significantly lower odds of receipt of any contraception, and then a significantly lower odds of receiving highly effective contraception. You can see similar trends in highly effective contraception use in the setting of a teratogenic medication, and I suspect that partly the reason we're not seeing statistically significant results is because of small numbers here. So, I think in my mind, this is more sort of hypothesis generating than anything, because it's hard to kind of make conclusions about quality metrics for something that only uses claims data, right, and not really reflects conversations with individuals. But it does make you wonder the degree to which there are biases, there's structural racism, there are other factors in play that go into choices for or not for contraception, and specifically highly effective contraception. So we take this as kind of a bird's eye view that requires, I would argue, qualitative work to really understand the reason for the racial differences that we observed. I'm just going to check my time and see where we are. Okay, so another thing that we've thought a lot about and that I'm specifically interested in is medication use and adherence to medications. So hydroxychloroquine, which has gotten a lot of press in the setting of COVID-19. We do not use it for that, but we do use it for lupus, and it is considered to be the backbone of care for individuals with lupus. So one of the things we were interested in was are patients in Medicaid getting hydroxychloroquine, number one, and number two, is it possible, since we know this medication is quite effective at reducing adverse outcomes and flares among individuals with lupus, are there racial differences in who is getting prescribed this medication? So overall, we found that about 40% received hydroxychloroquine or chloroquine, which is also used, within 12 months of their diagnosis, which is an extremely low percentage. So in general, in an academic cohort, so for example, when we look in our rheumatology clinic here at Brigham Women's Hospital, we're on 70–80% of individuals with diagnoses of lupus get hydroxychloroquine. So significantly lower here. And the sort of next question I had, well, maybe some of these patients don't really have autoimmune disease or inflammatory disease, so maybe that's why we're not seeing those rates, but 70% receive steroids. So, that's kind of arguing that somebody thinks that these patients have an autoimmune condition that probably requires hydroxychloroquine, but they're not receiving it. So interestingly, we found kind of the opposite of what we expected, that all racial ethnic groups were actually more likely to receive hydroxychloroquine compared to individuals that are white. And when I say receive it, I mean fill at least one prescription for it. So, and you'll see why that becomes relevant on a later slide. We found that younger patients were more likely, and that there were certain factors like alcohol use disorder, opioid use, diabetes, and end-stage renal disease, and also smoking, active smoking status, that were associated with actually a lower rate of this first dispensing of hydroxychloroquine. So the other hypothesis we had was that, well, maybe patients who are getting better care, getting more outpatient care, and who are more engaged in their care are similarly getting more hydroxychloroquine. So maybe part of the reason that we're seeing better outcomes among individuals who are receiving hydroxychloroquine is because these patients are maybe having better access to care and maybe fundamentally are healthier. And we did in fact find that. We found that patients who had more outpatient visits, who had more preventive care services received, were actually also more likely to receive hydroxychloroquine. So, I wouldn't describe this as an epiphany, but I do think that it does kind of stress the importance of getting patients engaged in consistent outpatient care in order to make sure that they're able to receive the backbone of treatment for this disease. So the other kind of piece of this was, thinking more broadly, what about, thinking about medication use as a quality metric, right? And let's look at patients who have kidney disease, where there's a really clear set of guidelines of about what these patients should be receiving. And here we found that only 22% of patients with new lupus nephritis received immunosuppressives. If you talk to a nephrologist, they will tell you that the number should be 100%. Only 44% received renal protective antihypertensives, and only 36% received antimalarials. The other thing that we were curious about related both to sort of how these medications are taken and also consistency of care. We found that adherence was very poor, as I'll show you in the next couple of slides, in this population, and that it was also associated, not surprisingly, with higher subsequent acute care use. So patients who didn't take their medications were significantly more likely to end up utilizing the emergency department visit and also being hospitalized. Oh, there we go. Okay, so this is a figure of group-based trajectory model, which is a kind of latent class trajectory where individuals are classified by monthly prescription refill rates. And then those data are used to estimate patterns of use over time. So this is a schema of lupus patients, so individuals with prevalent lupus, who were new users of hydroxychloroquine. And each month we calculated the number of days filled of the prescription and did this over the first year of use. So if individuals had days covered by their prescriptions of 80% or more each month, they were considered adherent for that month. And if it was less than 80%, they were considered non-adherent. So this is kind of the sort of patterns that emerged from those analyses. And you can see here that in the top group, which are the individuals who, for the most part, every month had about 80% or more of their medications in hand, there was about 17% of individuals who fell in that group. 36% refilled their medications maybe once and then never again. And then groups 2 and 3 were kind of in the middle. So maybe started refilling partially at the beginning and then kind of petered out along the way for group 2 and remained sort of maybe semi-consistent in group 3. So, the first kind of reaction I had when I saw this was, oh gosh, this is terrible, right? So really only 17% of patients are refilling their medications regularly, their hydroxychloroquine regularly when they're prescribed this medication. The other thing to remember is that just refilling your medication doesn't even mean that you're taking it, but granted, if you're not refilling your medication, I'm pretty confident that you're not taking it. So these are these trajectory models that you can see here and then the next thing we did was sort of estimating the odds of belonging to one of these groups compared to this group. And we found a higher odds of belonging to these groups among individuals who were younger, Black race, Hispanic ethnicity, who had codes for depression, and also who seemed to have less severe lupus. So, I think that, one of the questions in my mind was, is there a difference in what patients are being prescribed, and does that relate to the disparities in outcomes? So it seems like maybe no, right? But then the question is, something is happening after that first prescription. And there are probably so many factors that contribute to whether or not patients take their medications, right? And so, there has to be some intervention that we have to think about on that pathway in order to think about how we're going to reduce disparities. So in the interest of time, I'm going to skip over this slide. And then I'm going to talk briefly about this other question I had, which is, how much, thinking about that social determinant slide that I presented at the beginning, when we think about medication adherence, what contributes, right? There's so many things that factor into health behavior, and adherence is, I would argue, one of the most complex medically related behaviors, right? And, does where a person live affect the way they adhere to their medications? So we use Medicaid data here and did a series of hierarchical multi-level models where we adjusted for individual level factors like race, ethnicity, age, comorbidities, et cetera. And individuals were nested within their zip codes, within their counties, within their states. And one of the things that we found that was sort of interesting is that we found that there was a 20% reduced odds of adherence associated with living in a zip code with the highest tertile of percent Black individuals. We did not find a similar association with percent Hispanic or percent white. And interestingly, we did not find an association with living in an area with a high percentage of individuals living below the federal poverty level. And one question that this raised for us, and again, this is a bird's eye view, right, that in my mind requires further investigation, is that maybe racial residential segregation as a manifestation of structural racism plays a role in adherence behavior. We also found a higher odds of adherence among individuals who live in counties with increased hospitals, but we didn't find a relationship with number of physicians, pharmacists, or subspecialists. And we wondered whether variation in the quality of health resources in underserved areas may actually be more important than the actual concentration. And then my last slide is around acute care use. And this also directly relates to some of the interventions that I'll briefly talk to you about in a few minutes. So the next thing that we did was try to understand patterns of utilization. So how many of our patients or patients enrolled in Medicaid are repeatedly going to the ED and visiting the hospital for their usual care? We found that about 40% of patients were either moderate or high, persistently high utilizers of ED visits or hospitalizations, which is really a significant percentage of individuals. And we found persistently high use associated, not surprisingly, with higher mortality and with more severe lupus, but it was also, there were racial differences even after adjusting for lupus severity, and also an association with chronic pain, depression, and cardiovascular disease. And interestingly, male sex, older age, and hydroxychloroquine use were associated with less frequent acute care. So I'm going to move now for the next 15, 20 minutes into talking a little bit about kind of what do we do with what we find, right? And, I think that there is a role, certainly, and an important role to documenting disparities, to demonstrating them, to showing that they exist, and to understand pathways by which these disparities unravel. But I also think that there is a significant role that we need to play now that we know they exist to sort of think about what interventions we can do to begin to address these disparities. So one of the first things that we did was using a patient navigator system. So the goal was to determine whether patient navigators, so individuals who could help patients navigate their way through the healthcare system, to see whether this could improve medication adherence using individually tailored strategies. So like if a person had a patient navigator who understood exactly why they weren't taking their medication, could this navigator then design a strategy that's individualized for a person and help them take their medications better? And we did this for all rheumatic diseases, and the patients had to be on an oral disease-modifying anti-rheumatic drug. So Plaquenil that we had talked about would, for example, be one of them. So we decided that we wanted to not train necessarily a health professional, but rather a recent college graduate to see whether we could teach them about some basic rheumatology and pharmacology, and probably most importantly, teach them motivational interviewing. So we identified about 100 patients, 107 patients, mostly had rheumatoid arthritis. And there were about 69 who remained in the pilot for 6 months of follow-up. So the navigators called these patients every 2 weeks at most, and then every 4 weeks if the patients were like, stop calling me every 2 weeks, and assessed their adherence and developed individualized strategies to try to improve this. So our navigators had over 360 conversations with enrolled patients, and they addressed medication-related side effects, financial issues, doctor-patient communication barriers, and did a number of different things depending on the needs of the patients. So for about 27% of the patients, they facilitated communication, they provided education about their disease, about their medications, and then they developed and implemented personalized strategies like setting patients up for automatic refills, refrigerator magnets, text message alerts. They assisted with care coordination, and they addressed financial and insurance issues, provided support, and for several patients, expedited mental health referrals. So one of the more depressing findings of this was that there was really no significant improvement in adherence when you compared survey responses between the baseline and 6 months, and really no significant improvement in depressive symptoms as well. So one challenge here is that it's very hard to measure adherence. And we did not use pill caps, which is something that we're using now in another study that I'm doing, which I think would probably be better. And we asked patients to self-report their adherence. And that's very challenging, especially when you're asking patients to self-report when they know they're being watched, is the other piece. So it was interesting because our navigators found significant discrepancies in how patients filled out the surveys and in conversations they had with the patients. So it's hard to know if this intervention did not work, or whether there just may be better or different ways in the future to capture adherence. We did find that by the end of the intervention, patients had fewer medication-related concerns, so that's certainly a positive. But on the other hand, they actually had a more threatening perception of their illness, which one might argue may result in a higher likelihood to take their medications, but hard to know. Importantly, the navigators uncovered and addressed many concerns, but as I mentioned, it's very hard to sort of quantitatively measure these factors. So another academic-based intervention that we've been working on is something called the Integrated Care Management Program. So this has actually been in existence at our hospital center, so our hospital system, which includes Brigham and Women's Hospital and Mass General, in addition to a number of community hospitals. And the idea is that this program enrolls the top 2% of medically and psychosocially complex patients within our system. To identify patients, there's an algorithm that factors in age, comorbidities, acute care use. Patients are matched with a nurse care coordinator, and it's based in their primary care practice. And then needs assessments are conducted, and patients are matched with resources, given appointment reminders, and urgent medical issues are triaged. And among Medicare beneficiaries, which were actually the majority of patients who were enrolled in this program, there has been a significant savings dollar-wise and a reduction in ED visits and hospitalizations, length and also a reduction in mortality. So we were interested in seeing how lupus patients do when they're enrolled in this program. So we were able to use a combination of electronic medical records and claims data, which I can certainly talk offline to anyone who's interested there. It poses, I think when I started doing research, I had this idea that more data is like amazing, but then you realize that more data is more data, and it's fraught oftentimes with some mess. And so we have learned, at least in part, how to deal with that. And so we identified 69 patients with lupus who've been enrolled, and we tried to understand the differences in acute care use in the period before enrollment compared to during enrollment. And we did find a significant, so a 37% reduction in the rate of emergency department visits among individuals who were enrolled in this program compared to the year prior. And we saw trends towards reduced hospitalizations and fewer missed appointments, but neither of those were statistically significant. One of the other important factors or components of this program is that the nurses screen patients for social determinants of health. So we were interested in understanding what the burden of social determinant of health related needs were in this patient population. So we also were curious to see how many of them actually had these factors documented prior to enrollment in the program. So it was interesting because we found that about 60% had one or more needs documented before the program, but then after enrollment in the program, 95% had at least one need. I certainly don't think this is a reflective of suddenly patients having need when they're enrolled in the program, but rather the fact that they weren't screened before and now they're being screened. And I stress here the importance of trying to ask patients about these issues, because once these issues were truly uncovered and they were enrolled in this program where there was a nurse coordinating their care, the nurse was able to then connect patients with resources. And this happened for about 81% of the patients who were enrolled in the program. I think the challenge is understanding how much of those connection to resources actually changes outcome. I don't know what it is like in North Carolina, but certainly, for example, if our nurse or our social worker determines that a patient has trouble accessing housing, they can certainly get them on a wait list for Section 8 housing, but that wait list can take 2 years to move. So I think that certainly it's an important first step, but I think that the sort of next question is, how much of this actually is moving the lever, right? And I think that's kind of the next step of this research. So in my last 5 minutes, I want to tell you a little bit about the other kind of work that we've been doing, which are community-based interventions. I'm going to skip over this slide and talk a bit about an academic community partnership that I've been excited to be a part of for the past 4 more years. So working with a close collaborator of mine, Roz Ramsey Goldman, who's a rheumatologist at Northwestern, we have developed sort of both local in Boston and Chicago, academic community-based partnerships to disseminate lupus-related education in Chicago and Boston, with a primary focus on communities that have high percentage of African-American individuals in order to promote early and sustained care-seeking behavior, with this idea that if we can change care-seeking norms, we can get patients into care earlier, it may help reduce some of the disparities we see. So this is a schema that shows some of the community-based organizations that we've worked with, church-based organizations, and national organizations that have been a part of this effort. So we used a model called a popular opinion leader model, which has been developed by the CDC and had particularly been used to disseminate information around diseases that have some stigma attached. So initially piloted with hepatitis C, also used in HIV. And the idea is to train a community leader or a person who has a large social network and is trusted, and have that person disseminate the information that they're taught throughout their social network. So the information actually comes from that community leader and not necessarily from a physician or a healthcare provider. So we developed a training and for popular opinion leaders and recruited these leaders. We developed with our leaders palm cards, which they would, when they interacted with a member of their social network, they would kind of give it to them as a conversation starter, say, let me tell you about lupus, and then begin a conversation about what this disease is. Do you have any symptoms? And if you do, here are resources where you could go to think about getting care. So we recruited about 18 people in Boston, 19 in Chicago, majority were African-American, almost all except for one were female. And just briefly to show you the power of a model like this. So in Boston, among the 18 popular opinion leaders, leaders documented 97 encounters with a total of 547 community members reached. The concentration were in areas that were both of high area deprivation indices and also of high percentage of African American individuals. And this is these sort of circles demonstrate the reach of how many people in each of those areas the information was disseminated to. We had one popular opinion leader who went on to begin the first Lupus Foundation in Nigeria. And this is a photograph that was in the Lagos newspaper of the dissemination of some of the information that we had provided to her in a big and now annual conference that's held every year in Lagos. And in Chicago, you can see here that there were 124 encounters with a total of over 4,000 community members reached. And here it was interesting to see the difference in dissemination strategy between the two cities, where in Chicago, there was a much stronger focus on churches and church-based networks. And so there were large churches where sort of forums were held and information was disseminated, which in part relates to the higher numbers there. So I'm going to skip over these just to leave a little bit of time for questions, and just summarize by saying that, that our work and work of many others has demonstrated significant disparities in lupus care and outcomes by race, ethnicity, and socioeconomic status that really provide impetus for us to further address these disparities, understand the mechanisms, and develop interventions to remedy what we found. We know that social determinants of health contribute to these disparities, and we have seen that both academic and community-based interventions have the potential to reach vulnerable populations, to improve awareness, care coordination, access, and fragmentation, and to begin the process of addressing some of the social determinant of health-related barriers that are uncovered. But further work is needed to really think about how to embed these models into sort of standard of care practices, and also to really look at the downstream effects of, do they really reduce disparities in care quality and outcomes? And I would argue also to go back and think about what are the structures that created these disparities to begin with, and begin to understand how we can dismantle those as sort of a big next step in our work. So finally, how do we achieve health equity? And I think this kind of goes beyond just my scope as a rheumatologist and thinking about in general in our society. We need to understand the root and structural causes of these inequities. We need to recognize that racial and ethnic disparities extend beyond genetics, and we need to appreciate the heterogeneity within the classifications used. This is a significant limitation to, for example, using Medicaid, where we sort of don't fully understand how the classifications are given, and I'm sure that there is significant heterogeneity within the groupings that we use. We need to confront racism and unconscious bias. And we need to focus on groups that repeatedly experience obstacles to health and provide opportunities. We need to distribute resources in a way that contributes to healthy behavior. And we need to think about scalable interventions with outcomes that can be measured, that are built, I think, on community academic partnerships to really think about how we can move the lever. So I'd like to acknowledge many members of our team, both my mentors, my mentees, and our research assistants, programmers, biostatisticians, and our funding sources. And this is our group of section of clinical science here at Brigham Women's Hospital. So thank you. And I'm going to stop sharing my screen, so hopefully I can see all of you if there are any questions too.
So just to remind everybody, you can either type your question in the chat box and then I can read it aloud, or Dr. Feldman will, or you can unmute yourself and ask the question.
I'll jump in. Thank you, Candace. That was a lovely talk, and you brought up a lot of interesting issues. I think I'm going to ask you some questions focused on the community academic partnerships that came up in my mind. That was an interesting model, and I think it has a lot of applications. So how did you recruit your popular opinion leaders, and then how were they trained? Were they trained one-on-one or in some group setting? And I'll start with that, and then I have a few follow-ups.
Sure. So a couple of ways. So, I will say that one of the sort of interesting things is we did this both in Chicago and Boston. So the strategies actually were a little bit different depending on kind of the networks that I have in Boston and the networks that Roz Ramsey Goldman had in Chicago. So in Chicago, the Lupus Society in Illinois actually played a big role in kind of identifying people that they had previously engaged with who were leaders in the kind of lupus community here and there was also outreach done to church groups and other support groups in the Chicago area. Here in Boston, there's two organizations that I've worked closely with before. One's actually a youth community organization, and another is a community health education organization that one of their big endeavors is around academic community partnerships. So both of those organizations helped me identify individuals. There are also support groups in our area that we reached out to. And then, there's a support group here called Women of Courage that was initially founded specifically for women of color with autoimmune diseases. And so a number of members of that group who've become leaders and advocates for lupus in their respective Boston communities participated in as popular opinion leaders. So it was sort of an amalgamation of a number of different factors. And then the other thing is in our academic institutions, we sort of reached out to providers and said, do you have patients who, seem to be engaged in their community who might be willing to participate? The way we trained these individuals is we developed a curriculum actually in partnership with a number of our community leaders. So we sort of developed the first iteration and then went through a number of different stages of the presentations and then standardized them between Boston and Chicago, but then also had parts where we use sort of very local statistics in order to make them very relevant for the individuals in the city where they were living. And then had meetings. So we held, I believe it was 5 sessions, about 2 hours each in the evenings at a community-based venue in both cities. And our participants came, and we also had the ability for people to call in via webinar if they weren't able to be there in person. And, it was interesting because these were slated to be about an hour each. All of them ended up lasting 2.5 hours, and people didn't want to leave. And it was interesting because the group of popular opinion leaders actually became a support network for each other. And it was, and it led to conversations that were not at all in our curriculum. So for example, in the Boston group, there was a spotlight series in the Boston Globe that had just come out about race in Boston. And so one whole session, which we ended up adding an extra because we ran out of time, was just talking about race and health in our city. And that, and so it became a very kind of organic group where we talked about lupus, and we also talked about issues that were just sort of relevant in the time. And that happened in Chicago as well.
And one quick question so others can ask questions, but so your outcomes that you presented were more touches that the people had. Did you have anything embedded to try to get some of the other outcomes that you talked about that would be important to know, like whether you've moved the needle in changing people?
Yeah. So this is the biggest challenge, right? And so for us, for this iteration, in part because of the nature of the funding we received, which was, a 1-year grant that was then extended to 2, we were able to sort of assemble the group, provide the training, and then measure dissemination as our outcome. Unfortunately, the big question, the money question is exactly what you said, like, are we changing access? The big challenge with how to measure that is that in our cities, there's so many different places where patients can get care that it's very hard to measure, where, if a person went to our facility or a different facility, to really kind of assess that. We're currently doing a sort of second iteration of this around clinical trial enrollment and representation of underrepresented populations in clinical trials. And for that, I think we actually are going to be able to get citywide metrics on actual numbers enrolled in trials and diversity in trials. The one thing we tried to do that was not successful was we did, on those palm cards that these individuals would sort of hand out as conversation starters, there was a phone number that linked to the Lupus Foundation. And we did try to track the number of calls and also the number of sort of website hits that were potentially tied to our cities and also tied to, this specific outreach. And we really did not see much of a difference. So it's hard to know whether that was just not the pathway people were using, or whether that just wasn't a very good metric. But if you have ideas, I would welcome them, because that is the most important piece with a community-based intervention, especially when we're asking the popular opinion leaders to be the ones to help us collect the data, right? To try to understand how we can get the highest quality and the sort of most comprehensive data to really actually understand whether it changes that disparities that we're seeing.
Yeah, no, that it's very interesting. Thank you.
Good questions.
I have a question, but I feel like we're out of time. But I'll just jump in, I guess, with the, have you looked at or considered looking at the social support or social networks as a determinant of health? It might help explain some of the paradoxical outcomes, especially among Latinos who, although they're under-resourced in so many ways, their social networks are so rich, and that sort of helps buffer some of these negative outcomes that they may experience. I'm wondering if you've had a chance to look at that, and if you're considering also with the patient navigators, weaving in some of social support as an integrated part of what they do.
Yeah, that's a fabulous question. And I think, that is something in sort of the next iteration of this popular opinion leader model, I think that would be really important. And we were, Roz and I were just talking about this of, to what extent can we measure size of social network? Can we use some of the sort of social network theory measures to actually understand the degree to which that in and of itself contributes to sort of overcoming the disparities that we see, right? So, we think about the popular opinion leader as kind of the person to disseminate the information, but you actually wonder the degree to which the size of their network, and then the networks that each of the people they reach, and how that network in and of itself actually relates to the outcomes. I think that's super important and interesting as well. There have been studies that have looked at the role of social support in lupus that were done by colleagues of mine, and found that there was a significant association with support and improved care utilization and outcomes as well. So I think the ability to kind of leverage that factor would be very important. And I do think that there is also a role to sort of thinking about differences by race, ethnicity, and also how people define their social networks. I think also differs by culture. What people call family, what they call friends, how they define it. And I think trying to understand that more would be very important. I do think that specifically in the patient navigator study we found that one of our navigators was Spanish speaking, and we found that her role as providing support, not just for helping patients communicate in the system, but also just actual support specifically to non-English speaking patients, was a really important piece. And when we did the satisfaction survey for patients, this is what they highlighted as one of the most important roles that the navigator played. So I think you're exactly right, and thinking about how we can measure that better and quantify that network relationship would be really interesting and important.
Thank you.
So I know we're getting up to the time in which we need to wrap things up, but I just wanted to, if anybody has another quick question, feel free to ask it. So I'll give another 10 or 15 seconds for that.
I'll also put my email address, so please feel free to reach out to me if I can answer any questions or be of use in any way. And I'd love to talk more, and maybe someday we can see each other in person and have another conversation, which is always so much nicer. But this was also lovely. So thank you for inviting me. I appreciate it.
Yes, and we'd like to thank you again for talking to all of us today. Dr. Feldman did put her email address in there, but you can also send any questions to me and I can make sure that they get to her. I'm also going to be sending a follow-up email to everybody in the coming days with a link to access the recording of the talk in case you like to listen to it again or to share it with your colleagues. Before everybody leaves, it would be great if you all could fill out this brief anonymous poll about the presentation. It just helps us with planning for future presentations. So thank you again, Dr. Feldman, and everybody who joined.
Thank you.
Bye.
Bye.